there isn't a day that doesn't go by, okay, when, I'm confronted with a patient that has, like 20 or 30 different drugs. And as a consequence, I think it behooves all of us to have some knowledge and have some appreciation and some sort of practical wisdom as it relates to, how you deal with all of these drugs and the potential for drug-drug interactions. And I wanted to sort of keep this sort of germane to the chronic pain echo sessions that we've been having now for several years. And so my intent really today is basically to describe some of the pharmacokinetic and pharmacodynamic mechanisms that involve selected drug-drug and drug-disease state interactions, and then look at some tools and some monitoring and surveillance strategies to recognize and perhaps try to avoid some potential interactions, and then look at some strategies, and these are just basic sort of overview concepts as to how to manage potential interactions. So I think we need, I'd like to start out with some of my discussions with operational definitions, and I think it's important to know the difference between pharmacokinetics and pharmacodynamics, okay? So pharmacokinetics, or abbreviation PK, really has to do with, what does the body do to the drug? Okay, I mean, that's the simple approach to look at, I think, the concept of pharmacokinetics. And it really, as most of you are aware of, and it involves absorption of the medication, the distribution into various tissues or spaces. It has to do with the drug's metabolism and also its excretion. And then if you contrast that with pharmacodynamics, which is really, when you look at pharmacodynamics, it's really what does the drug do to the body, as opposed to what the body does to the drug. So I think that it's the interaction that takes place between the drug molecule and some receptor or target tissue, okay, or some site. And that's the difference really between pharmacokinetics and pharmacodynamic. Now, when it comes to drug-drug interactions, you're going to see both pharmacokinetic and pharmacodynamic types of interactions that can take place. And even in some cases, you may see both, even in the same person. So what is a drug-drug interaction? It's where you have the concomitant or even previous administration of two or more pharmacologically active entities or drugs, and how it results in something that's unexpected or unintended or unanticipated. So example, you can have two drugs that interact in an antagonistic type fashion, in which case, if I use simple math, 2 + 2 does not equal 4. 2 + 2 equals something less than 4. So perhaps one of the drugs interferes with the other drug. So that drug that's interfered with may have less of an effect than you might anticipate. And the converse would be a synergistic type of effect, where 2 + 2 does not equal 4. It gives you something greater than 4. So now you have a perhaps more heightened response from that specific drug involved. And then you may have just something totally unexpected, and that would be something that would be considered idiosyncratic. Now, besides drug-drug interactions, you have to be aware of drug-disease state interactions. And that's where you have one or more drugs may have a positive or negative impact on some pre-existent condition that the patient may have, or actually the converse also may be noted. It's where the concomitant comorbid condition has a significant influence and maybe a profound effect on one or more drugs that the patient is taking. So let me give you some examples, okay, of a drug-drug interaction, either pharmacokinetic or pharmacodynamic in nature. We can use oxycodone plus diltiazem. And you're going to say, well, I was hunting for specific opioid type interactions that might be not only significant, but perhaps relevant to practice. A lot of your patients could be on an opioid and they have a concomitant either hypertensive history, or they have history of a arrhythmia, maybe AFib, and perhaps they're taking diltiazem. So diltiazem, actually could be a potentially significant interaction between diltiazem and oxycodone. Okay, and that's on the basis of the hepatic metabolism of oxycodone. Okay, oxycodone is metabolized by the 2D6, okay, isoform of the CYP450 system in the liver. And if you have someone who takes those two drugs, okay, concomitantly, what could happen? Well, you may affect and may decrease, okay, the metabolism of the oxycodone. Okay, so in which case oxycodone is metabolized to a NOR metabolite, so it's called noroxycodone, and it's also metabolized in part to oxymorphone. So if you're inhibiting metabolism with a drug like diltiazem, what's the end result? You're going to see more of an effect with the oxycodone. So you may see a more heightened response, okay, from the oxycodone. And from a pharmacodynamic standpoint, again, where you have a drug affects target tissue or has some profound effect on a receptor site. If you have a person who takes, and this is where we always get nervous with people who take opioids plus benzodiazepines, because of the potential for additive effects with respect to sedation, respiratory, effects, plus, just profound, even optimization and potential, obviously, lethality with that combination. So in my way of thinking, an opioid plus a benzo is an example of a pharmacodynamic interaction, okay? What about drug disease state? Can what would be a good kind of classic example? And that's morphine and a patient who has renal insufficiency or renal failure. Because remember, morphine is metabolized or glucuronidated in the liver to a 3 and a 6 glucuronide metabolite, which they both can accumulate in the face of a person who has reduced creatinine clearance. And now we have someone who now has a sort of a heightened response from the morphine, okay, with respect to all of the classic opioid type side effects that one sees with morphine. And that's why patients who have chronic renal insufficiency, one, I think, has to worry about people not even on not just acute care, but certainly chronic opioids where the person's renal function is deteriorating. That's a signal and that's a red flag with respect to perhaps the need for a medication change or even a switch, perhaps. So if a drug or a drug disease state interaction is actually possible or likely, you have to always ask the question, and this is something I think Mark could relate to and myself, is it significant? Is that drug interaction likely to have a significant, profound, detrimental, even lethal outcome? And that's where you have to be able to interpret, I think, the literature, and you kind of mix that with your own experience with patients who take drug combinations that potentially are problematic, and then you have to make a decision as to whether or not it's going to be significant or not, okay, for a given patient. So when it comes to significance, and you're looking at the literature or case reports, you have to try to ascertain what exactly happened with those two drugs in question. Okay, when did it actually happen in the course of treatment? How significant was it? Is it perhaps the kind of interaction where the person can wait and all you simply have to do is monitor the patient? Or do you have to take some course of action where you have to either make a dosage change, you may have to switch, you may have to remove the medication from that patient's regimen, okay? So the thing you have to remember about significance with respect to drug or drug disease state interactions is there is much inter-patient variability regarding the significance. Okay, and that's something that I think as a principal or a tenant, you really have to kind of take to the bank, that because it happens in one specific patient or one scenario doesn't necessarily mean it could literally translate to your patient that you're dealing with. Now, what about drug interactions with opioids? This is just a short list of a lot of different possible drugs that could interact with opioids. And so in that case, let me sort of just give you a brief case, and I'll use a few cases to perhaps highlight some of these issues. We have a person who's 45 who had a long-standing history of mood disorder, and he presents to the emergency room with a hand laceration from a lawnmower, okay, which is, very significant, especially for mid-July. So during the assessment, the patient has about a 7 out of 10 pain on a visual analog type scale. The emergency room resident orders, now this is again, realize that everybody's going to jump on the fact that this resident gave the person Meperidine, okay, which by all, the American Pain Society does not consider it an appropriate analgesic. I know that. Let's substitute even maybe morphine for Meperidine. But I'm going to try to give you a look at a classic drug-drug interaction when it comes to opioids. So anyhow, the only thing pertinent to the history is the current meds. So the person takes lisinopril for hypertension, aspirin, and takes Phenelzine. Okay, for those, everybody know that Phenelzine is MAOI, okay? So so there is a red flag here. The little person who's waving the red flag says, oh my gosh, okay, this person is on Phenelzine, and this resident who's now July, probably an intern. Okay, this is the month not to get sick, okay? He's gonna try to treat this patient's pain with Meperidine, okay? Well, this is an absolute contraindication to Meperidine. Not just the fact that it's an inappropriate analgesic, okay, period, but in combination with the Phenelzine. Because what you could see, okay, and you can substitute other opioids, let's say morphine, that has a potential, may not be to the same significance, okay, the word significant, but you may see a serotonin-like syndrome, okay, because of the Phenelzine plus Meperidine. That's a classic drug-drug interaction with opioids. And what do you see? You see excitation, sweating, seizures, delirium, okay, et cetera, et cetera, et cetera. Does everybody know the case of Libby Zion? And I actually forgot to bring it with me, to be honest, but this was the case that took place in the 80s, okay, where you had a person who came in who was basically treated and turned by a resident and an intern and a junior and a more senior resident. Okay, what ultimately turned out to be was managed, and for these two precipitated the serotonin syndrome in this young woman who at the time was 19. Okay, the intern at the time, this took place in New York City, one of the big hospitals. Okay, and this intern was taking care of 40 different patients. 40, okay, 40 patients. Okay, and the resident who was the senior to the intern was at a different building and available by pager. Okay, so long story short, the decisions that were made with this patient led to the therapeutic decisions, led to the serotonin syndrome, and the person died. Okay, so those of you who have cursed and bitched and moaned and complained, okay, about duty hours, right, the new duty hours for residents, this is the case that led to duty hours, okay, because of having an intern, okay, try to take care of 40 patients in a hospital, led to bad decisions, patient died, okay, and as a consequence, you now have duty hours. Okay, so you can look up the case, it's very famous, and it's the Libby Zion case.
I'll send it out.
Okay, and I can send I have a little synopsis of the case that I'll send to the rest of the troops. Okay, another sort of interesting kind of scenario where you could look at drug-drug interactions is HIV-related pain, which is a distal symmetric peripheral neuropathy. It's either the disease itself could do it, or sometimes the antiretrovirals that are used to treat HIV can cause this peripheral neuropathy. It's manifest by bilateral paresthesias, neuropathic pain, and you treat it very similar to, post-herpetic neuralgia, the same sort of types of medication. And in some cases, these people may even need opioids. So we have a 42-year-old person who is taking triple antiretrovirals for about 5 months. He takes Bactrim or cotrimoxazole, which is trimethoprim, sulfamethoxazole prophylaxis. He's gained weight. He's feeling good, but he's had this tingling, numbness, pain in his extremities, especially his toes. So he was taking acetaminophen and with little relief. And then the last visit, amitriptyline was added, and then he can hardly walk because of his foot pain. And the pain is so significant that it keeps him awake at night. So on examination, his lower extremities were normal. His dorsalis pedis and posterior tib pulses were present. His ankle jerks were diminished bilaterally. So the treatment plan for this patient was to limit standing and walking, wear loose shoes, soak his feet in ice water. And I'm not going to comment as to whether this methadone was an appropriate regimen for the patient, but suffice it to say, this person was put on methadone as an analgesic, okay, and then protective measures for his feet with respect to a patient who has an insensate foot. So the red flag here, again, not criticizing drug choice, okay, but methadone. And how come? Well, it's because he's taking one of the antiretroviral Zidovudine, which can't interact with methadone. Okay, so you got to remember, anytime you add a new drug to a person's regimen, okay, as we'll get to in a few minutes, you need to be aware of, will it interact with that patient's current regimen? Because it can be very significant. So in this case, you're inhibiting the hepatic and renal clearance of Zidovudine because of the methadone, okay? And then what the side effect profile that one sees is sort of a heightened response to the drug, and it looks like almost a person who's having an opioid withdrawal, okay? So just keep it in mind, okay? Here's a classic example of a drug-drug pharmacokinetic interaction, okay? Now, what about the sort of the classic drug-disease state interactions? You have a middle-aged man who has a long-standing history of chronic pelvic and low back pain, and he was in an unrestrained motor vehicle accident around 2014, okay? So he comes to the family practice center for a new patient visit and to establish care. So there's a typo. The MVA was 2014. He had a pelvic crush. He has PTSD, depression. He has noted on a previous EKG to have prolonged QT around 510 milliseconds. He's hypertensive. He's also a cocaine abuser, and he quotes an allergy to morphine. So medications, he's on Zoloft, sertraline, and the rest you can see, plus extended release, oxycodone, and a laxative, okay? So during the intake, the patient states that his pain has never been well controlled, and he has friends, okay, get this, okay? He has friends who take methadone with good relief, okay? And he inquires whether he would be a suitable candidate for methadone. So what do you think? And I don't think anybody in Zoom land is going to say, yeah, I think this is a good choice, okay? But if by chance, okay, and the reason is you have to say, which is multifactorial, okay, is because he's a guy who has a prolonged QT. Okay, and you have to remember that methadone has the potential, okay, especially above 100 milligrams, which is a big dose, okay, to prolong the QT. And the consequence is torsades de points, or some say torsades de points. Okay, it's twisting of the points. The twist is that it could kill you, okay, because you get sudden VTAC, and that's it. And that's a little tracing in the lower right-hand corner of VTAC. And if that doesn't correct or is fixed, then you don't have to worry about anything, okay, at that point, okay? So, there are a number of screening guidelines that have been developed that can inform a person how to approach a person if you're going to consider putting the person on methadone, okay? So obviously you have to decide and risk stratify the patient. Are they a candidate? Really for whatever reason, but you have to discuss or know, does the person have structural heart disease? Do they have a history of arrhythmia? Do they have a history of syncope? Okay, some would suggest prior to methadone, you get a baseline EKG and then a month hence and then yearly. That's, there are new guidelines that update what you see on the slide, and it's on the reference list in red, okay? And that's just for those who would like to pursue it. But it's similar to what you basically see on the slide. Okay, so with a person with a QT on the drug that goes from 450 to 500, what do? You monitor the patient, I think, is what you do. You consider changing the medication to a different agent. You consider and look for reasons. Is it electrolyte? Is it concurrent medication? Is the potassium low? Whatever. Okay, that may require a change in dose or drug. And then, just be aware of the fact that you can see drug interactions, and they're not something that are not really uncommon with methadone. I mean, a lot of drugs have the potential to interact with it. I worry about mostly hearts when it comes to methadone, obviously overdose and respiratory depression, etc. But from a cardiac standpoint, you do have to be careful and assess their regimen if they're taking methadone, and make sure you know what the baseline EKG is, okay? So before prescribing or recommending any opioid, you review their current medication. This is, pharmacology, basic. Everybody's had this, not just prescription, but non-prescription regimens. So how do you assess non-prescription? I do a head-to-toe review of systems. Mrs. Smith, what do you take for a headache? Do you use anything on your scalp for, dandruff, seborrhea? What about ear drops, eye drops, nose drops, skin care, cough, cold, congestion, okay, constipation, diarrhea, upset stomach, feminine hygiene, over-the-counter contraceptives, rectal care products, hemorrhoids, fissures. What's left? Your feet. So foot care, okay, athlete's foot, corns, calluses, bunions, whatever. You use any non-prescription products on the person's feet, okay, or do they use anything on their feet? So quickly, you go head to toe. There's another approach that's called avoid mistakes. So A is assess for allergies that the person may have. Does the person take vitamins, herbal supplements, nutraceuticals? No, in some cases, what persons have taken in the past, because you could see carryover effects, you could see prolonged effects that could impact that person's current regimen. So what other things have they had in the recent past? Okay, and that includes the non-prescription medications. Okay, you're also assessing for potential interactions, right, with these folks. Plus the deeper dependence, just because of, patients, if they have opioid use disorder, if they have alcohol issues, whatever, you should have some handle on dependency, and whether within your judgment that person may require a contract, okay, prior to prescription of something. Mendel has to do with genetics. Okay, is there a family history of benefit or any issues with drugs? Because then you can pick, perhaps, even though this is in its infancy, medications that are based on pharmacogenomics. Okay, so that's and plus, I even ask the patient, as you do, what has worked for you in the past, because if it has helped, that gives you great insight into how to approach treatment with the person. If they've had, benefit with drug A, B, and C. Okay, so you evaluate for the medication list for comorbid conditions, as I alluded to, that could affect pharmacokinetics, pharmacodynamics. You evaluate the comorbid conditions that could affect the drug itself. That's important. And then, when it comes to drug-drug interactions, pharmacist, physician, nurse, physical therapist, occupational therapist, respiratory therapist, chiropractor, whatever. Okay? You cannot keep this stuff in your head. You just can't. Okay? So what Charlie likes to carry, okay, as far as a compendium, is lexicomp, clinical suite, and has a drug interactions, okay, which is all based on and well referenced, and it's current and it's updated as the whole suite is updated. So what are your options? You have compendia. I just put top 100 drug interactions 2018, and these two fellows who wrote this book, it's a textbook. Textbooks are classically out of date, probably 2 to 3 years prior to publication. Okay, but if you want a hard copy reference, that's one option. There are others. Okay, you have drugs.com on the internet. You have the smartphone apps. Don't forget your colleagues, the pharmacy, physician, nurse colleagues who may have, can give you insight into potential drug-drug interactions. Plus, I'll put a plug for the Drug and Health Information Center here, which is run by the School of Pharmacy, and there's an 800 number, 352-2501, okay, that you could ask if you have specific questions. So the thing is, when it comes to any kind of compendia, or any kind of tool that you use, okay, that, there may be some variability in the data or the information on the same drug-drug interaction. So you should have a source plus something that validates it. So always try to search 2 or more databases if you can for the drug-drug interaction in question. But if, what if that you can't avoid, you have to have these drugs in a given patient? Well, you monitor the patient to make sure nothing bad happens, okay? If something bad happens, then you're gonna have to make a decision. Do I decrease it? Do I pull it? Do I, based upon the adverse effect, you may have to support the patient, okay? As far as perhaps, example, maybe vital signs, so perhaps, whatever it may be. And then I think that the crucial comment is you learn from the incident, okay? I mean, I think everybody could attest to errors. No one should be in the audience who says, no, I just never made a mistake. I never hurt a patient. I'm wonderful. I never did anything bad. Well, if you can say that, God practice because those are far and few in between. But if it does happen, learn, okay, so that you don't do it a second time, okay? I think sometimes errors almost have to happen because it makes you better, because you learn from it, and now I'm not going to make it a second time, okay? So with that, it was just a basic overview. Do you guys have any questions about how to avoid badness when it comes to drug-drug interactions?
Everybody, you are muted. Feel free to unmute yourself.
Hey, Charlie, that was really good. Thanks.
Thank you.
I had just a kind of a quick question, maybe, or kind of a question for the group. So in residency, when we used methadone, I think I always saw it used as kind of the last choice. I mean, it was the thing that we used after everything else didn't work or it failed or a patient had been through that. And so I think kind of by extension, that's how I think about it now. I just wasn't sure if that is really appropriate, or if it's like, if you could maybe, anybody like to share like what sort of a patient you might think about methadone early on in their treatment regimen as opposed to late.
Well, I think if I will be the first to admit I've had virtually little experience with methadone, okay, for analgesia per se, but if you read the textbooks, okay, and you look at metabolic disposition, okay, you may see it if the person absolutely has to have an opioid, okay? Now that's a whole other discussion, okay? But let's say they truly have chronic renal disease or renal insufficiency, okay? You will see some advocation because it's a little cleaner in those folks. Now it has lots and lots of baggage, right? In terms of how it's dosed and monitoring and potential for fat distribution, leaching, if you don't dose it appropriately and wait in between dosing changes and you're not careful about the medication, and it can creep up and bite you, right? Because it'll accumulate and then it starts to leach and then boom, you have an overdose on your hands, But I think I have seen a lot of advocation for the renal patient if you have a person who needs a analgesic that has to be from the opioid, class. But, beyond that, I've had very little, I just don't have a lot of methadone experience, not in pain management at all, I just don't see it used here at all, ever. I have rare patients who will come in on the inpatient service on methadone for pain, but it's been the exception. And even, with respect to, I see far more patients, on buprenorphine, with respect to opioid use disorder than methadone maintenance, at least here, okay? That's just one little practice, so.
We used to use it a good bit years ago. It was our go-to long-acting opioid. Mm-hmm. It's very effective and it's very inexpensive. It's treacherous because it'll build up very quickly. And so, particularly in the elderly population, you would maybe give 5 milligrams once a day and reassess in 4 or 5 days. And then if they're okay, then maybe go to twice a day. Now, with respect, now it's almost taboo to even think about using it for a lot of not so good medical reasons. However, if you have a neuropathic pain patient who you absolutely cannot control any other way, there is evidence that methadone may have some NMDA properties that could be useful. So start low, go slow, monitor the EKG, and as any other thing, just be attentive. Mark?
Right. Yeah.
I'll even add in that one of my very, very favorite pharmacist colleagues, other than Charlie, of course, who practices in palliative care over in Maryland, does a pretty good presentation a lot of times across the country, and basically starts out by saying methadone is like the greatest drug known to mankind, and then spends 1 to 3 hours educating on how intricate the dosing and selection is. And those two things typically conflict, and it makes for good conversations afterwards. Because it's very tricky. But for those that know for the very few that know what they're doing, it's in the toolbox. A little add-on, I don't know, I haven't heard anything recently, but to my knowledge, as of about a year or two ago, there is a drug company that's working on getting one of the two enantiomers to the market, because basically you got the right hand, you got the left hand, and they're not talking. One does most of the bad stuff like overdose, and I believe the QT torsades. And then the other side is actually the mu opioid / NMDA activity. And if you could pull off separating those, you might be onto something there. I just don't know where those studies are off the top of my head.
That help you, Greg?
Yeah, I was just wondering. I was thinking back to this one guy that came to Establish Care with me a year or two ago, who was on methadone. He moved here from California and was on methadone for restless leg syndrome, and I just had to be honest with him that was just something I had absolutely no experience with whatsoever, and that would really require the care of a neurologist, but that I wasn't aware of any neurologist that I had ever seen prescribe methadone for restless leg syndrome. And I don't really know why a syndrome that has a Parkinsonian component, I didn't understand really why methadone would be of any benefit other than just sedation. I mean, just knocking them out so that they just didn't notice that they were having those symptoms. And I just didn't really know where to point that guy. And he just sort of indicated to me that, really kind of wasn't. I mean, of course, obviously patients bring all sorts of different stories and baggages, but so do providers. And and I just wasn't really sure how to take. I just was never really like, maybe this is a medicine that I don't know, I've thought about incorrectly, because it always strikes me as a medicine that is just a minefield of problems, and so it's not really something that I think of wanting to subject my patients to, let alone myself. So I just didn't really know if that was appropriate. It sounds like it's not unreasonable.
You're not alone there, and I can tell you that I was with you until about a month ago, when our chief of neurology sent me a patient with intractable night movement of his limbs, with an article that said that high-dose methadone has been reported in cases to treat this. And I had the same opinion you had. And so we started slow with this dude, and he ends up on 5 TID of methadone, and he said that it's a miracle, and he's able to sleep at night. So that's a real thing, but it's a 1 in a million thing. So if
Rick, that's almost exactly what was going on with this guy. It was almost exactly the same situation, and the story does not end well for my patient. It's really kind of sad, because I referred him a couple of different places and tried my best to help the guy. And he got to the point where he ended up having to move back to California, actually, just to he had just kind of an incredibly disruptive situation in his life, because, I just honestly didn't know what to do with him at that point for that day. But again, that's the one patient that I've seen in my career with anything, similar to that. But I was just kind of curious. It's interesting to hear that's maybe a thing.
Exceedingly rare. And so what I would say is, 1 in a career you might say it's possible, but 5 in a week, you're going to say, yeah, no, this is not good. So,
Hey, you're already done. You got your 1 year.
Yeah, you're in.
What with methadone? Here's probably an off-the-wall question. What's the going back to morphine milligram equivalents, like love them or typically hate them? What's the highest MME in a patient utilization that anybody's ever seen?
Oh, about 2,000.
Rick says 2,000. Anybody go higher than 2,000? Other than me. My answer is 3,240. 3,240. How do you get to that? A patient with sickle cell disease, typically up and down days, 27 methadone a day, every day for 10 years. Yeah. And there was no better case of, other than the whole sickle cell should be going up and down thing, of opioid-induced hyperalgesia than I've ever really. The recommendation for treatment was lowering the dose, and it would have helped. And it was a managed care scenario, so your tax dollars were paying for it. And then didn't necessarily go down that route, but 27 a day for a long time.
Really hard to come off of, too.
Yeah.
Very hard to wean off of.
Yeah, how do you go about that?
It's a long, long time. Even small doses, it may take months.
Anecdotal, but figured we'd throw that out there.
Awesome. Thank you, everybody. Thank you, Dr. Ponte, for the presentation. Yeah. Thank you, everybody, for the discussion. Do you guys have any other questions or things you want to talk about? We have time. We have about 15 minutes.
I was listening about that uncontrollable restless leg-like symptoms. I mean, I have a patient right now. Okay, I'm just requiring help. I'm going out of context. That I felt that he has restless leg and he was not able to sleep at night. And I'm tried all the medication. I sent to the neurology. They said he does not have restless leg, and they did everything. But at the end of the day, he's still having symptoms, and nobody has any treatment. So while we are discussing this restless leg, anybody has any suggestion for this kind of problem?
Do you know offhand what he's tried? What you?
Yeah, I tried gabapentin, Requep, and just a second. Just a second. I think I tried everything except Klonopin. Okay. I've tried Trazodone, I've tried Neurontin, Requep. I tried leg stretching exercises, melatonin. He tried over-the-counter, that Q9 tablets. Yeah, that's all. The blood level of everything, like including ferritin, everything looks good. He does not have sleep apnea.
One of the things you mentioned was gabapentin. That might be way too detailed, but do you know what dose or how you went about that?
I went up to 300 milligram, but after that it was making him feel more tired and everything, and he was not noticing any benefit between 100 to 300 milligram.
great to hear as a little kudos there of you said you went up to that start low, go slow is really important. What else we got going? Any diabetes or?
No, he had chronic kidney disease. Chronic kidney disease and hypothyroidism.
Yeah. This is Charlie. It's funny every time I think about patients who have restless leg syndrome, and if you use one of the, like let's say UpToDate as a reference tool, and you look at the different drugs that have been tried to manage restless leg, it's like this long. Okay, and as soon as you see that, when you have different drugs from different classes that have different activities, okay, from a pharmacologic standpoint, that means to me, okay, that nobody really has a good handle, okay, not only on treatment, but the pathophysiology, because there is such inter-patient variability on what works for a person and what doesn't. So there's no, apart from Requip, which I probably see more use of here, but it's very difficult because there is no one good that I know of approach to treat this. Okay, and like I say, I think the red flag always waves in my face when I see a laundry list of medications that are used to treat a condition. That means nobody really knows the best approach to take. And it's sort of hit and miss, and you just try different things. And what works for your patient may not work for Greg's patient, okay? Or maybe it will, but it's a trial and error kind of approach. And I don't really know of anybody who has yet come upon the drug that works the best in patients with it. Now, that's just my take on the issue. I think what Mark was getting at is that gabapentin, for different conditions where it has been tried, tends to be underdosed in a lot of patients. And you sometimes don't push the dose to the point where it actually could have some benefit. Why? Because of the side effects. Okay, the ataxia, the dizziness, the drowsiness, those are sometimes rate limiting steps to pushing the drug, and then you're kind of stuck. And then you perhaps try a different drug with a different kind of approach and a different mechanism. So you wonder if some of these things would work if there was sort of, especially if there was a dose response. Okay, but you don't know that because there's not a lot of, I don't think, primary literature that that looks at all these different drugs in these classes to try to pick the best drug to treat something like restless legs. And it's probably because there's different reasons why people have restless legs. It's not just one pathophysiologic entity. It's something different, perhaps, than in one person versus another. So that means it's a mess. Okay, and I think your approach with respect to trying different things, is about I don't know of a better approach, frankly, unless some of the spokes have better knowledge or perhaps better approaches or things that may have worked in many of their patients, and you could say, well, this seems to work in most, and maybe this is the approach you should take, but I don't normally get that with folks, and maybe the spokes could chime in on that. Like Lucia or or Jenna or anybody or Greg, do you have any
I treat a stepwise. So basically, every patient that I have that has restless leg syndrome gets a sleep study. It just to start. But I kind of do that with a lot of sort of people that I think have fibromyalgia. I do the same sort of thing too. So I think Dr. Pollywall I think that's great that you tested that person for sleep. The other thing I do is I give them iron, irregardless of whether or not they're anemic, actually, because I've seen some benefit with that. Then I move to Requip, and then I push the dose until I feel confident, like 2 milligrams at night, where I feel confident that that's not going to work. The next medicine I use is either mirtazapine, Remeron, or trazodone to try to help, which it sounds like you tried the trazodone. And then after that, gabapentin. And then after that, I don't know where you would go afterwards. I see Tegretol used sometimes, but it's just, I think and if you look it up to date, it lists kind of the mirtazapine and the Tegretol and the gabapentin as kind of those other medicines to try, that Dr. Ponte said, it's just this long laundry list of medications. But when I first got out of residency and started working here, I saw people that were called restless leg syndrome on a million different things. And so I've just tried to kind of standardize some sort of a stepwise approach to that. And mine's not based on anything other than kind of what UpToDate says and what seems to work, kind of at the widest for most people and then up. I mean, there have been patients I've had that have tried a bunch of different medications, and I gave them iron pills and their symptoms just went away. They just did remarkably. But if somebody can take an iron pill once a day, as long as they don't have hemochromatosis, and they are doing well without any other medications with that, I think that's pretty successful. So,
yeah, thank you for the suggestion.
We have time for maybe one more comment. I was wondering, does anybody have any physical recommendations? Or I don't know anything about it. So are there stretches or anything that can be done?
Well, I was just wondering about possibly trying TENS to just kind of have that distractive input and maybe get the muscles going a little bit. It wouldn't have to be necessarily very specific, but it's so accessible these days. Cool. Shaquille will sell it to you right off the shelf. Yeah. And I think it's a modality that's really underused for a lot of.
So where do you put it? Just on the calf? Where do you put it?
Yeah, I probably would put it on the major, the major regions that seem to be most restless.
Yeah.
I don't know that quadriceps is usually too much of a problem. I think it is mostly lower leg.
Yeah. Right.
Give that a try. Cool.
Has anybody done that? Has anybody tried TENS units? No. Yeah. Okay.
I've never tried them, but I see them at Rite Aid. So
yeah. I mean, they're really, really easy. And again, it's a modality that has some very good studies behind it for chronic pain overall. Sure. And I think what you're saying is, I was thinking about this presentation of restless legs being so different. Then it has to be something about brain processing of it if everybody feels this differently. So I wonder if the same kind of cognitive behavioral plus, non-pharmacologic stuff might be an approach.
We have it. Let's see. We have our
now. I think at the management center we've got CBT going on.
Dr. Gross was there, but he's not.
Yeah. So just spitballing off the top of my head.
Yeah, that's fine.
Right.
Yeah.
All right, guys. Well, that about ends it. So if you guys have any other questions, definitely email those to me. I'll make sure to forward them to everybody. Our next session is August 1st, okay? If you guys have a case, we are in need of a case for that. I don't know if it's going to end on or be on this day, but we have a workshop scheduled. They're trying to push it back to the 15th, even though we haven't had any hard, I don't know, whatever. I planned it for the 1st, and then they pushed it back on me. Anyway, we need a case because it's going to be an educational session, basically, to get more people involved. All right. Talk to you guys later.
Hey, Caitlin, tell John he's hurting my feelings.
Well,
he's got to call me back.
Okay, I'll let him know. I'll make sure. Jay and I see him today. I don't know. Right. I'll go track him down in clinic or something.
No, that's fine. Thank you.
Okay, see you guys.
Bye.